should make a report on. And I know that you know that one of the things that we need to do in our case study is to project family practice principles. So every of the case, we should be able to project this. And also, in this presentation, we'll present approved tools for assessing case book. I believe that all of us should know the mind of the examiner, the mind of the college, whenever you submit your casebook. We have an objective way of looking at that casebook. So we'll show you the tool, which I'm sure every one of you are privy of. And at the end of it, the whole of this should galvanize in us producing acceptable and standard case reports and family case study. We want to remind us of the goal of the training. All of us in the training is to produce specialists with knowledge, skill, and attitude to function as a family consultant, family medicine consultant. And that you do that independently and should be able to function not just as a consultant, you function as a full clinician. You know, you be a teacher, you're a researcher, you're a leader in the family medicine. That is the whole essence of the training, which I'm sure all of us are aware of. And to also remind us about the general structure of fellowship, we know that in the college, we have both membership and fellowship. The first 2 years after your primaries is membership, which after passing, you pass on to fellowship. I'm just mentioning fellowship here because casebook is where we, writing of casebook occurred during the fellowship. And this slide is just showing you the outline we all know: rotation, research, casebook writing. And the essence of this training is to consolidate what we have learned in membership and gradually take responsibility. Remember, you have to become a consultant, a trainer, a teacher, working independently and helping others. And we also expect that at this fellowship level, we should be exposed broadly and continue on family services, continuous and integrated exposure to family care. And we should be able also to co-manage our patients with other specialties, especially functioning as a primary care physician, as a first line doctor. Casebook writing, we all know, is one of the books we need to submit during fellowship outside the citation. And this slide is just remembering us of the distribution. That's still the distribution. And most times, for trauma and orthopedics, a lot of people confuse. We know what trauma should be, preferably an emergency traumatic case, orthopedic. You should be able to differentiate that, because most times people mix them up. Okay. Every case that you are going to report or manage, there are certain expectations. Remember, as a family physician, our main core of concentration is patient-centered management that will address the disease, the illness, the sick role, the whole person care, and be able to work out, make mutual decision-making with the patient. The whole essence of this is just to remind us of the three important things we must bring out in a patient: the disease is suffering from, the illness experience, and the sick role, which will be that's the structures that are available for this patient to be able to recover. and the biopsychosocial assessment and management of patients. So every case presented should be able to capture the essence of this. As we go on, we'll see more on this. And also, the expectation should be that we should be able to use family medicine tools to be able to manage all our patients. In fact, every case that is reported should be able to utilize this in one form or the other. And none of the cases that you report that should not. And we should also be able to manage chronic disease model or to apply chronic disease model and disability management. Remember that most of the chronic cases you have to manage in continuous basis, and the patient must be knowledgeable. We must be able to increase the patient's skill in staying alive and be able to also utilize all the structures around him so that he will get well at the long term, not just today. That will inform what drugs you use, the costs, the environment, everything. Chronic disease model. And their communication skills should be also very vast, being able to motivate patients and also breaking bad news. As one of the tools we should also use home visits, home-based care, and resolution of dilemmas in family practice. Well, some of those dilemmas are so vast that you should be able to resolve them, especially not micromanaging a patient, but on a family basis, family medicine basis. And the next slide shows the formats that every case that you present must take. There should be a title page, declaration, certification, dedication, acknowledgement, table of contents, introduction, which you all know. Introduction is just trying to tell you or tell your reader where you manage this patient, what the hospital, your selection, and everything, in at least so that somebody will know where these patients are from. Then the read case report from 1 to 15. And bearing in mind those selection criteria, that is the different distribution. And one of the number 15 should be the family case report. For individual case presentation, as usual, as we all know, the biodata is very important. And the biodata must contain everything that you know about this patient that should be presented. If it is a lady, you must always capture the last menstrual cycle, the parity. If it is a child, all the parameters for child, weight, weight of the child should be there. So those peculiarities should be reflected in your biodata. The history, all aspects of history of present the complaint, history of presenting complaint, fever. When we get in, you understand that the fever should always go with the history of presenting complaint. You don't. That's where you should capture it, because by the time you leave their history of presenting complaint, one should say, oh, what was the fears in this patient, the expectation, and why he needs to come and see you. So the college have stressed is that fever should be part of the history of presenting complaint. Other histories that you know, and the family social history, which is very, very important, because that's where you pick a lot of your, be able to identify most of your personal, patient-centered care components, be able to manage your patient. After that, the physical examination, the usual thing, and most of the time after the general, you should start with a system or the system that is affected. Diagnosis and differentials, management, discussion, And this discussion must be discussing the patient. Remember, family medicine manage the patient, not the disease. Discussion the patient along with the disease and whatever lesson that you learned from this. This discussion is very, very, very important because depending on your discussion, one would know whether you are really reporting a family case. Then conclusion and references, at least 10. It's also to draw your attention that references should be minimum of 10, current, and not more than 10 years from the time of submission you are submitting your paper to the college. And each case must be 8 to 9 pages, because if you exceed that, you may likely overshoot the total page, which is 120 to 140. So you must maintain that 8 to 9. Family case should be 14 pages maximum. So how can we choose acceptable case report? This slide is very important. And if you do not get anything in this presentation, you must get these slides. And I'm going to post it to our WhatsApp group, the whole of this presentation. Remember, all that the examiner knows and expects is what you as a resident should also know, so that by the time you submit your book, you should be able to look whether you have met this criteria. I'm sorry, because this I just had to cut and paste. That's why you may not see some areas. But what this is, there are 7 steps that you must take in choosing acceptable patient or acceptable case, a patient for case report. I want to stress that again. There are 7 steps you need to take, 7 things you need to note and make sure you assess in choosing a patient for your report. And I will call this 7-step, a guide to 7-step family practice patient management guide. What we may say FPPMG 7 is very, very important. So the first thing you need to, before you select is, why are you interested in this patient you are presenting? Is it the clinical history that is peculiar? Is it the physical examination? Is it investigation about medical issues? For example, you may say a patient that had a fracture of femur. Why did you decide to take, maybe instead of doing X-ray at the start, X-ray after 6 weeks, and X-ray X-ray after maybe correcting the fracture, and 6 weeks, and etc. Then you decide, oh, this may not be possible because you may not be able to afford you. Instead of doing that, you can choose a few X-rays to do. So all those kind of a thing are things that you can also bring out as a family physician. Because of the costs, because of this, you may not be able to do all the tests, despite that those tests would have been necessary, but not compromising what you do to this patient. So you must be able to identify why this patient is catch your interest, and why you need to report. Or is it that this patient has brought a window into diagnosing something in the family? You know, for example, a patient that has been battered, you know, may reveal some problem within the family, the mother and the father, and something like that. You know, maybe they're not having a good relationship, which may also help you to be able to take care of this child. Must find a way of getting those. So there must be reason that you are interested in this patient. Or it could be a psychosocial issue. Number 2, what clinical area does this patient fall into? Is it pediatrics? Is it psychiatric? Is it obs and gyn? What evidence are you using to guide your intervention? In intervening in this patient, what are you using to guide your intervention? For example, why do you decide to give parenteral anti-malarials instead of oral? You say, oh, because this patient is vomiting, or maybe it's too weak to take by a mouth and something like that. So all those things must be shown. Or why do you decide to manage this patient on outpatient basis with regular, frequent visit instead of admitting, into the hospital? Maybe because of costs, or maybe because they don't have somebody that will come and stay with the patient and the rest of things. So you should be able to there must be some evidence you have shown to guide your intervention. How did the patient family social context affect presentation? How would the patient illness experience affect patient's family, social world, and near future? All these things must be taken. For example, if that patient is a breadwinner, how would that being admitted affect his immediate family? The child staying back from school for a particular time, how would that affect his studies? You see need that, oh, you should inform the school or something like that. So what family medicine tool would serve you best to highlight relevant issues? You must always identify the tools, because that makes it a family practice management. And the last one is, what family medicine intervention can this patient benefit from? So many interventions. You need to go to the family home visit and all the rest of things. So there are a lot of, so this slides is very, very, very important, so that by the time you start writing your casebook, you must use this slide as a guide to be able to answer some of these questions, because you are not micromanaging any case. Your case should be to have a family medicine perspective. The next slide is the style. Well, the important thing about the style, keep it simple, use short, familiar words. Don't go to too much jargon. It must be straightforward, short sentences, and write it in past tense. That's as a reporting sentences. Be specific, be concrete. Don't present any abstract something. If you are sure, be concrete. Say what you mean and what you say. The next slide we are going to look at is common mistakes that have been identified during examinations. A few of them we will mention some, then later we'll mention some. But let me quickly say that this slide shows some mistakes, especially in style. Mistake one is poor use of English, and most of the reason is that residents wait to submit so much cases. So I've seen a few sitting down to write the whole 15 and then submit to a supervisor. Which should not be the case. So the solution should be that every patient should be allowed your as you write your case, give it to the supervisor to look at it, because when he corrects one, you can use that one to bill others. But when you put so much, with the poor use of English, grammatical errors, it would even be very discouraging by the time the supervisor look through and cancel so many things. So batch by batch. And also they use long sentences and unclear meanings. Most things happen because there's no time for you to really step back and work. And also submitting those things at a rush. So supervisors also rush. They are human beings. So always get the supervisor engaged at onset. Essential data most of the time are ignored because you do not have a clear purpose in writing that patient. You don't have no grasp of requirements of the case writer. That 7 steps that are highlighted before will help you to be sure that all the essential data in whatever case you report are captured. So you use a casebook tool which I will also show you, because the marking of this casebook as its object is objectively done. It's not determined by, yes, the examiner looks at it, but he doesn't use his own thought. He has some marking scheme. And it's good that all of us should know the marking scheme and be sure that all the essentials are gotten. And most of the time, some of these things are very boring, not interested, because you just sit down and cook. You know, you want to report a case of malaria, go to Facebook and copy all the symptoms, all the examination, all the, it doesn't make any sense. So it looks boring when you read as a family physician. So you must always make sure that you proactively model whatever patients you present in line with that 7 steps, and give it to your supervisor at the right time. Let's also look at the logical sequence in presentation. The sequence of presentation according to standard medical format. We have already shown you that. And we have also said that women and children, when presented, you should capture their biodata. A woman should have LMP parity, a child should have weight, height, if it's possible, or if it's possible. Then the illness experience should be presented in the history of presenting complaint to complement the description of the disease. It's very, very important that that should be done. And that will also highlight the reason for the encounter at the end of the history of presenting complaint. This is very, very important, because by the time examiner reads through your history of presenting complaint, these things are not there. In fact, he lost interest in other things. So must always capture the feedback and reason for encounter. Another aspect is that the family and social history should express the biopsychosocial considerations of this patient. Remember that through the family and social history, you'll be able to do so many things, identify so many components of person-centered care management, which is very important. You'll be able to determine the structure that is available for this patient to be cared for. You should be able to identify problems that this patient could encounter if you are not managing him properly. One will be able to see how empathic you were, in identifying some of those problems. So these tools may or may not be showcased depending on the trust of management. Not all of them you can be pictured, but at least those family and social history should be able to pick some of these things. And most of the time at the end of your diagnosis, or the end before your diagnosis, you can do a summary, but this is optional. If you do such a summary, let it be that it is done consistently throughout the case, and the primary diagnosis should be presented. The diagnosis must be diagnosis, then your differential diagnosis. This is very, very important, so that at least that will show examiner you are thinking, and your discussion will be based on such presentation. Psychological aspect that is unique. About all this we have presented thus far is that every resident must always be guided, must be fully guided towards biopsychosocial model of care. That's the most important thing. And whatever patient you present, this must show, and consideration for the context described for patient must be seen to weigh in the clinical management. Whatever management, the way you are going to manage this person will depend on what you have found out, not necessarily the disease. What you have found out in the illness, what you have found out in the social aspects of this patient. The other aspect of the sequence is, I'm sure by now all of us know the component of the PCCM. So the third component should be illustrated. The third component has to do with reaching common grounds for management plans. Should be able to showcase how you discuss the diagnosis and the mode of treatment and how the patient has now come to share, accept or what you want to do. You share common grounds in terms of maybe a side effect of drugs and why you need to use these and the rest of things, and in the costs. The plan will also show physician consideration of psychosocial realities of the patient and will be in realistic in view of the health costs. That's PCN 4, 5, and 6. So health costs, patient specific prevention to optimize your relationship with him, and being realistic about resources. That's time, money, the men that are available, and the machine. So these are very, very important that you should be able to showcase this PCCN and biopsychosocial aspect of their management. And once these are not shown, you can be sure that when you look at the tools, you lose so much marks. Another aspect that I want to stress is that, yes, we are family physician, but whatever management you are taking, it should be at the secondary level intervention. When I say secondary level, you understand secondary level of care. There's a primary care, secondary, and tertiary. At least showing some that is an intervention by a specialist. And you must also exhibit a high level of care received because, I think, because you are a family physician. For example, if you just write about malaria and just talking about giving Watem and the rest of things, without any specific thing that, maybe was it malaria with anemia, and why was it so? Was it because he is sick or he sought for intervention late? Things like that should come out so that it makes you look like a specialist managing this patient. And let me quickly say that whatever mode of management, you cannot be penalized because of how complex the management, as long as you use family medicine tool in trying to give your patient the best, and you master it in your intervention. Demonstrating advanced skill in managing of this patient. This will include skill set that would obviate the need for another health professional. What we're saying, we are not saying that you should not refer this patient to a micro specialist, but in whatever you do, you must reflect that, look, you are a specialist. And if you need to manage this patient, you can do that. And that could form part of your case, but you follow it up and coordinate the care in a very holistic way. Okay. I'm stressing that again because at times you may be the only specialist available there. For example, you need to do a CS for prolapse of cord. It's a special surgery that you are there as a specialist. Should be that you should be able to manage that. And the skills reported should not take you out from your primary duty. That's the most important thing. Whatever case you report, no matter how complex or how little they are, it should not take you out from family medicine discipline. Must make sure you use the tools, use the intervention, various intervention, family medicine intervention method. Okay, just to relax a little, let me just bring out these slides of special notes. When we are talking like this, it means that there is no ideal case presentation. You can make your own case different from, it's not that you have to always look for a case that somebody has reported or the way it's always reported. No, let your case be what you are interested in and bring out. In fact, that's exactly what we want, so that we have a lot of these cases, on our shelf. And let me also say that the faculty or the examiner judge the quality of care you offer, and not necessarily whether it has happened before or whatever. So the context of best practices must be considered with social, cultural, and economic realities of that patient. And also, the faculty or the examiner does not, assessment of case is not about identifying investigation that you have not done or the procedure you have not done. But if you say you do a procedure, you should be able to defend that procedure based on some realities and be able to explain that procedure. That's the most important thing, So you must, before you make a procedure, if you say anything, make sure you be able to defend, because most of the time, that's what it is. For example, if you don't have a three-way valve for EBT and you decide to use syringe, you can explain why you do that. Nobody will penalize you because the normal thing should be to use a three-way valve for EBT. Examiners will also test question and intervention reported. So when you are defending your case, it's what you have reported, because most of the time they realize, and as we go, you see some of those problems that is seen in most of these cases, that you write something very beautiful, but you can't defend it. Please, as we present, just write down things that you may put for discussion. Those are the casebook presentation. And now the family case study, which is very, very important. Family case study. The purpose and structure of family case study is to assess the ability and the demonstration of the influence of family-based behavior choices on health of one another. Because health of one person may also affect, or maybe as a result of a family member that has tendencies for that. So you want to see your ability to assess that and how you've been able to demonstrate it. And also to appreciate the differences in and demonstrate the perception of family support. Very, very important, family support, as opposed to actual support. Because if you have identified the structures available for this patient to be managed, you want to be sure that those structures are actually giving that support, not just perceive, because he has a mother and a father that is working and is having enough money that you believe that they will be able to assist. You must actually assess the support, actual support, of the family members. Maybe when you're having family conferencing, or maybe home visit, or using some tools like the family environmental scale tools, which really use in practice, but can be used. This will help you in such listening to plan interventions, interventions that are outside the patient. So external people that be able to help this patient to recover. And also to use home visit when truly indicated. Not every time that there has to be home visit. There must be a true indication of such home visit. And you should be able to use that to improve the health status of the family members as identified. And also use the family as a unit of care to support members. I've said that in adherence, in lifestyle changes, etc. Purpose and structure still. To use motivational speech or speaking to get the entire family adopt a new lifestyle for the benefit of members, especially in non-communication able disease like hypertension. If you talk to the whole family, let them know that, look, this can is a familial tendency for it, and modification of food for the patient will also mean for the family. And the children can also help the parents to remind them about taking the drugs and the rest of things. So such motivational things can help the patient. And also to showcase the complexity of follow-up of different personalities within a unit. Another aspect is to capture and analyze similarities between similarities and differences among 2 to 3 generations. Remember the family history, you have to draw your genogram at least for at least three generations, and see how what you are presenting or what the patient is having is maybe is recurring in the family. The influence on one another, dependence or not. So what each generation is aware of and another, and the interpretation of different issues, different values. What and why these are kept in the closet. You must be able to explain that to them. And the family case study, and you have to note the format that each member of the family has an independent entry. If you are getting about 3 people in the family, you need to report, all of them must have their own entry. For example, the biodata, especially those ones that are not common. Then you make a report. Then another one, the same thing. A minimum of 2 generations should be presented. We've said that before. And the common biodata for family need not be repeated. For example, address, you don't need to repeat that. Address, those common things should not be repeated if they are the same household, the tribe. Family genogram is best presented after the history of presenting complaint and not before family management presentation, because most times you see you start with the genogram before you start the HPC. So in even the other cases report, if you need to use any tool or genogram, please do it after your HPC. When you do after your HPC, it captures so many things. Okay. At this point, we want to look at the assessment tools. These assessment tools we share with residents so that you are all going to become consultants, and there are tools that you need to be familiar with. And apart from that, your casebook must be matched with these tools. It is very, very important. This thing is very crowded, but I will try to end this particular show and see whether I can enlarge this a little. Just a few minutes, please, or a few seconds. Okay. I'm sure this should be a bit larger. So what I'll do is that I will bring this. Okay. Okay, let's start this way. The tool has the scoring, which is on top of it. It can be adequate, 0 to 2 points. It can be you need improvement, 3 to 5 points. That's what the examiner will score you. If it's inadequate, it's either 0 or 1 or 2. If it needs some improvement, it's 3 to 5. So you can score. The other one is he has met expectation, 6 to 7. Next one is that it is exceptional. That is, you merit commendation, 8 to 10, which means you have done it excellently well. Then the other aspect of it are those criteria. What are the things that we need to note in each of this? Is on the column. The criteria, so we will look at the grammar, punctuation, spelling, formatting. and we'll score them on that this thing that I've said. The next thing is logical sequencing. Have you arranged your presentation? Let it follow the logical way, history of presenting complaint, the whole history, and all what I've said, examination, management, discussion, conclusion. Relevance, the relevance not below secondary care level. That is what you are presenting. Is it at the secondary care level? You know, if it is not, then and scored all that. Accuracy of diagnostic process. In arriving at your, did you use the right thing? You know, so the next one will be demonstration of procedural skills. If you say you do a particular skill, is that the right skill? Can you explain it? Then the next one will be depth of knowledge of what you are doing when you are discussing. Does it show that you understand what you are doing? Then the biopsychosocial, which I've been saying every time, biopsychosocial determinant of health. Very important. The next one is the PCCM, whether you have captured them. But I want to bring that out. PCCM, you can look at it. The 1 to 2, you have identified 2 components, you have used up to 3 components, you have used all the 6 components. Then the next one, the next criteria will be cost issue. Cost issue. Then the next one will be referencing. So once you get the reference, you know, it should be according to what we've said. Then after that, the total score will be over 100. So that whatever you get, it is objectively done, not subjective, so that you don't feel that, oh, a lecturer or examiner doesn't like you, that's why he scored you wrong. That you must satisfy those criteria, sorry. Okay. Please, I will post this, and I will also send the, I had sent it before, and it is very, very important, this assessment tool. Everybody must know it. And when you are writing your case, please mark yourself before you send it to your supervisor to do. You can give it to your colleague to also look at it to be sure that these are covered. So the casebook tool that we have just presented, I've tried to just make a summary. The tool, know that it was developed. These are some things for TOT. You are becoming a consultant. That's why I didn't want to take this out. Know that every time the consultants sit down to develop these tools, and it was accepted. And there had been a little problem here and there. People believe that it's so simple, and whatever it is that it's very, very objective, and it is used. Okay, the other side, how to use the tool outside examination. That's the one that really concerns us. Please, as I said, we must avail and use this tool to guide what needs to be included in patient management report, in your report. It's very, very important. And this can be used in patient management to remind us every time of the scope of work we are expected to do. Even in your own thing, try to see whether you've been able to capture this in every patient that you see. And it must also be used in writing up patient management report to ensure compliance. So it's not just for the exams, it's for you to prepare and use it. The tool is called, and so guided minimum expectation are required. We have said that. We have said it, and I've shown you all the area. 0 to 2, 3 to 5, you know, and the rest of things. Don't think that it is this thing. If you show expertise, you get what it's supposed to be. Okay. This slide is trying to also look at, I'm sorry, the presentation looks a bit lengthy. just to capture those things. The common drawbacks, most cases, they notice are managed like mini subspecialists. For example, if you need to marry, do a bone fracture, you manage as a specialist. It mustn't be so. There must be family practice aspect of it. And it takes time to write these cases. Because of that, there's a delay. So as you write it, please give it out. The college is considering whether they should start writing this from membership. That is being looked at. And we hope over time we'll be informed about this. And they have noticed that there's a lot of dishonesty in writing up of the case. People cooked, people copied, people used textbook, as I've said, and there is a plagiarism has also been noticed. You use somebody's own and copy. And in fact, most of these things, once you do like that, you won't be able to defend it. And the case write-up does not match up performance. Can write up very decent, but at defense, they realize that many residents fail. And we are still worried about the role of supervisors, maybe because you are not using them. So the college is very concerned and is trying to define the rules of ensuring that the consultants are really involved. As I said, cases are managed as subspecialists. So these are, the training. She's not a subspecialist training. It is a family medicine. I'm showing this slide again here because it's very important. These 7 steps. So please, we must take these 7 steps, very, very important to guide us. Well, these are just a few things that the college is trying to do. I don't want to waste time on that. About the dishonesty, the college is trying to see how you can register every case you see in your ward and you feel you should write. You should take it to your consultant to register with the supervisor. And the supervisor, when he compiles maybe up to 5 or 10, he will now register with the college, just to be sure that you are not dishonest about what you choose, not the one that you just write 15 cases and throw on your consultant. And I want to tell you that the supervisors are going to be very, very strict. Without seeing the case book and the case, you may not be accepted. And so that you don't just write up what in dishonesty. Okay. The matching of the case. Most time you write a case you cannot defend. As we have said, we want to encourage that there should be departmental presentations of cases. You write a case, sit down, present in the department, let them ask you questions. As they do that, you become more, you master that case and you'll be able to defend areas. You'll be surprised you will identify a lot of areas you did not consider in management of that patient. The role of supervisors, we have said, so don't work on that. In summary of what we have tried to do, we've tried to see how you can recognize a good patient management. We have said that, why are you choosing that patient? And we have tried to draw your attention that the college is encouraging us to select a patient and report right. And also to also develop skills to present your case in a family case, or family case study. We have highlighted that. And so these summaries we are writing down are some what we have already said. And also there should be standardization of patient management. The 7 steps are very, very important. And we are looking forward to seeing residents interacting with each other, especially in this case management. Do a peer review of your cases so that you will see whether that needs to be done. So these are thank you so much. It's quite a lengthy one. That is, I think it was, those are the references of some of this, and we got a lot from the GOT that was organized last year. And Mrs. Irabo already make a contribution on this. So thank you very much. And we'll leave this time for questions and answers. Are you with me?
Thank you very much. Thank you, sir.
Yes.
Thank you so much, sir.
Can I mute my mic or I leave it on?
You can leave it on, sir.
Okay. Yes, the coordinator can coordinate the questions and coordinate everything. Or do I need to coordinate it?
No, sir. I will coordinate it, sir.
Okay, thank you.
Yes, sir. Do we have questions? Registrars? Comments? Registrars, comments, questions?
I wonder if the registrars are feeling like, maybe this is not their own part. Remember, our chief said something. He said,
all members,
the college is thinking
let me
of
quickly
making.
say that this is for everybody.
Yeah.
For everybody.
Everybody.
Because very soon,
yes,
members will start collecting. In fact, it is encouraged that some of the cases, especially the family case, can even start from membership. Because it may be difficult for you to get all those cases during fellowship with all your listening. So the college do accept some choice in choosing, getting some cases, even when you are doing membership meditation.
Yes, sir. Thank you, sir.
Okay.
Okay. Senior registrars, please let's ask our questions since our registrars are still thinking about theirs.
Can I remove the screen?
You can leave it there, sir.
I can leave it there, okay.
Sure. Dr. Basse, I thought you were.
Yes. Thank you very much for the presentation, sir. Chief, I wanted to ask a question, or you'll probably get a clarification. I'm currently writing a case on a 52-year-old carpenter who had who presented with recurrent epigastric pains. Now, basically, the diagnosis was that of peptic ulcer disease on account of infrequent use of non-steroidal anti-inflammatory drugs, off-the-counter prescriptions, you know. So what was highlighted basically in the case was health education for people to know that there are dangers in actually carrying out self-prescriptions and just buying medications over the counter, because that's basically what predisposed this patient to having the gastric ulcer. But the issue now, sir, is during the procedure, I did an endoscopy for the patient. So, but I was skeptical about reporting that I carried out the endoscopy. You know, it's not because I can't defend it. It's because I kind of felt like it wasn't the norm. So in this particular case, do I report that I carried out the endoscopy as there are pictures of the endoscopy done and evidence attached to this particular case? So do I just leave it as patient had an endoscopy done, or I carried out the endoscopy?
No, just like I said, the college does not penalize you in any case that you have seems to go into specialist area, as long as this case is managed with a family medicine perspective. You can do ultrasound, it's expected. If you work at where you have endoscopy and you have a hands-on, and you can report that you did endoscopy, maybe with the assistant of the consultant in charge, and this way what you saw. You can put those pictures. There's nothing about that. They're not going to penalize you. If there's any examiner that knows endoscopy, maybe he will ask you, how did you do the endoscopy? You know, things like that.
Okay,
But
sir.
they can't penalize you at all. It depends on what you defend. If you ask you anything, you defend it. And I always want for special things like that, especially endoscopy, do it with a consultant. If you know that you have done it, it's always, you tell them, look, you went for the training, and it's expected that as a family physician, some of these procedures are things you can do.
Thank you very much, sir.
Yes.
In addition to the last question, sir,
Yeah.
from the past case book I've gone through to see how it went from our seniors, I noticed that they tend to put in that at every patient management, they will state that they discussed that case with a managing family physician who agreed with their management. So I want to ask now that is that necessary, or is it compulsory that for every case we must always make reference to the fact that a managing family physician was involved or a managing specialist was involved?
Ekis, you broke off.
So,
I don't think Chief heard you.
No, I'm hearing.
okay.
No, it's breaking, but I'm hearing.
Okay,
You're
so,
asking whether continue.
Whether it is important, whether it is compulsory for us to state that in every case that we have to discuss the case with a supervising consultant and who agree with our line of management, and before we now went ahead to do all this.
Yes, if you yes, there are some cases that you may need to do that. For example, let me just give you a typical case. If a patient comes in with amputation of the or maceration of the thumb that has been crushed, you get me?
Yes, sir.
Yes, and you need to do amputation. You realize that it cannot, and you know importance of the thumb.
Yes, sir.
Good. You cannot just say, oh, because it was macerated, everything, and maybe even if you made it at the point of gangrene and you amputate. Those are kind of cases that, because of the legal implication, because of the problem to the patient and the rest of things, you consult with your senior. Oh, this is the situation. Let him assess with you. In fact, it's even expected that you even get orthopedic surgeon to also have a look. All of the 2 or 3 people will agree, you do amputation. So such cases there are some cases, not everyone that you need to confer with the DC. For example, if you treat a psychiatric patient that you need to use any of the psychiatric drugs for a long time, or you need to do some psychotherapy, it doesn't stop you from, working with a psychotherapist and making you know that, look, this is what you did with the psychotherapist over the period and the rest of things. So it depends on the kind of case. And if you know that it is you that did it, does not make any reason for you to, For example, if you do a prostatectomy, one expect that is a specialist this thing. You can make such a report, but it's good that if you do it with a surgeon, a specialist, you will show more impetus on what you report. Because as much as possible, remember, you are not reporting the micro aspect of the disease, but you must put in a family perspective, a family medicine perspective. Is that okay?
Yes, sir. Thank you so much. Other questions and comments? Sir? Dr. Ebusa.
Please check the group chat. There are some questions in the group chat. Ask so you can ask you.
I hope I can get to that. Then I have to remove my screen.
Yes, sir.
Let me stop sharing so that I can get to the chat. Okay, sir, please, the placement of review system. Is it after the HPC before the physical examination? Usually. Remember that most of the review of the systems, some of them that are related to the presenting complaint, it's good to review them within the history of presenting complaint. Do you understand?
Yes, sir.
So after that, you take the whole history before you do any other one that you feel you should do, review of system before the examination. It's just the normal thing we've been doing, but as much as possible, it's always beautiful if you review a system that is related to the complaint within the history of. It's beautiful, For example, if a patient comes with dyspnea and you need to review CVS within that history, it's beautiful. It captures a lot of things before you finish the history of presenting complaint than to go and review it separately. Also, summary of cases should be before the physical examination or after the physical examination. Summary of cases, when you say summary of cases, which one? Is it summary of the patient before you manage? It's always good to do it after examination. You summarize it briefly, then you make their diagnosis. Is that okay?
Yes. Hello. Good evening, sir.
Yes.
Hello, sir.
Yes.
Good evening. Thank you for the presentation, sir. I'm asking these questions because during my national exam, I was faced with, I was told that the review of systems should be just before the physical examination. And also the summary of cases, summary of that case. That's the history. You should summarize the history. I was taught that the review of system is just the way you said it. It should be before, just immediately after the HPC. But I didn't want to argue. I was like, okay, and that was part of the corrections they gave me. So I had to remove the ROS from there and put it right before the physical examination. Then the issue of summaries again, well, National says it's not compulsory. West Africa says it's compulsory. So
it's not compulsory.
Okay, because it
but
adds
if you
to
do for one, you must do for others.
Do for all, okay. Because I was saying that because it adds to the increase in pages. So I don't know, based on what you've said, that means there is a standard, so we don't have to do it. So it will add to, give us some leeway with the pages when the SLs are writing. Thank you very much.
Thank you. It's not compulsory, but if you do it, you must do it for every one of it. It must be consistent. That's what I presented. I will send this to you. The format, the Nigeria may have a different thing. I will also post the format for West African College. As much as possible, you must try and follow that format. If there is any, most of those things changes, but let me say that your FIFA must be part of the HPC. That's the most important thing. Must be part of the history complaint. And okay. Another this year, I'm asking this because I encountered in my national exam. Oh, is that the same thing?
Yes, sir. Yes, sir.
That's the one.
Yes.
Yes, sir,
okay.
that's the same.
That's no problem. Okay. My background is a bit busy. I would have used.
Sorry, sir, it's me. I wasn't able to talk earlier. It's me. I just asked the question. Thank you, sir.
No problem. My question is about complaints. Is it allowed to put all the symptoms the patient have, or we highlight some severe symptoms? It's always good to pick the severe ones. Some of the symptoms can always be put within the HPC. Sometimes a patient, even in the clinic, a patient comes in with a list of symptoms. You should be able to pick the important ones because some of those symptoms are maybe secondary to the other one. as much as possible, don't put too many. But 2 or 3 symptoms to me is okay. Is that okay? That's the
Yes,
history
sir.
of presenting complaint. And
Yes, sir.
writing it, you can make it as a prose or you can itemize it. There's no problem about that. Okay.
Yes, sir. Thank you so much, sir. Any more questions? Our consultants, please, you can.
Before we close, I want to plead with every resident, please. This presentation is very, very important. Let's try and see how, because the college is concerned about improving our input in case reporting. And remember that we are all looking forward to becoming consultants. Once, if you put all this in practice, by the time you become consultant, it's going to be very easy for you to supervise. So every case you see now to write, please, let's use these tools. And also, you people have not been keeping us busy. Right now, you don't need to even give us hard copy. All the consultant or your supervisors have this, and just send it to them, even if it's not time for you to start writing. By the time you make 1 or 2, 3 comments, you'll see that you will be so enriched in writing this. So thank you very much for listening.
Thank you, sir.
And good night. Are we still doing the case presentation?
No, sir. No,
Okay.
sir.
Okay.
Yes, sir. HOD, ma'am.
Okay, good night.
Well, maybe very soon we should start again. Well, anyway, after the second, let's see how February is.
To start a case presentation.
Because it won't be a crowd, so we won't be breaking any rules.
No problem.
All right.
Dr. Chado, sir.
Okay. Good night.
Dr. Chado, any closing thoughts, sir? Dr. Lucia, maybe you should just round up for us.
Dr. Chado, any comments? Dr. Otopa.
Why is it you that we see? Okay. Good evening, everyone. Thank you so much, our teacher and trainer, Dr. Udofia, for making this presentation. We have been reminded and we have also learned new things here. I suppose the presentation also is a wake-up call to all the people who have taken breaks from writing cases. Shall I call their names? No, let me just leave you alone. You know yourself. Please resume writing cases, following what we have just heard. Yes, thank you. Thank you very much.
Thank you so much, sir.
Okay. So good night, all.
Good night, sir. Thank you so much, sir.
Good night, sir. Dr. Topa typed in our appreciation